Services Research Roundtable Gathering. My name is Paul Buller. I'm a professor in the business school at Gonzaga University, and I'll be your host tonight. I'm one of the facilitators of the Health Services Research Roundtable, which I'll say a bit more about in just a bit. While we certainly miss the in-person gatherings that we've had in the past, we thought that we would hold this event virtually in sensitivity to our frontline health workers and others who are still pretty well inundated with the continuing demands of the posed by the pandemic. And so virtual gathering isn't ideal, but we hope to be back in person next spring. We're really looking forward to exploring the topic of today's program, behavioral health and telehealth, opportunities and challenges. Even before the pandemic, there were increasing numbers of people in our community experiencing anxiety, depression, alcohol and drug abuse, and other challenges. The pandemic has only accelerated the demand for behavioral health care, with disproportionate numbers of youth and members of the BIPOC communities. At the same time, there's a growing shortage of behavioral health providers and resources. One of the positive developments during the pandemic has been the proliferation in the use of telehealth and other technologies to provide access and care. Delivering behavioral health through telehealth and these other means is promising, but challenges remain. So we hope our panelists will help us explore the topic of behavioral health and telehealth as we go through the evening. Today we have three community experts who will share their experiences and their perspectives on the intersection of behavioral health and telehealth during the pandemic and looking to the future. We'll have some breakout rooms later in the program to discuss and identify possible research questions and how they might be explored into the future. Next slide. Before I introduce the panelists, I just want to thank our HSRR steering committee members. You see them displayed here. What's unique about the Health Services Research Roundtable is that it's a collaboration of faculty from the 6 institutions of higher education in the region, along with a variety of community health partners. And it's very rare to have this many institutions cooperate and collaborate on a project. And we have been in existence since about 2016. As I say, this is our 8th networking event. And we're trying to be a networking organization that brings together faculty who have interest in projects, research, and student projects, and community partners who have needs for resources, expertise, and help solving day-to-day problems and clinical problems. So we hope this collaboration and networking bears fruit through these networking events. Next slide. I also want to thank Amy Lee. You met earlier. Amy is the Marketing and Events Coordinator at the School of Nursing and Human Physiology at Gonzaga, and she's our technical expert and will help us get through the evening. She's much better able to do that than I am. So thank you, Amy. Next. So here's the program. I'll be your MC. I'll be introducing the panelists in just a minute, and then I will pose a series of questions to each of the panelists. And following a period of time, about 35 minutes or so, we will open up to chat questions from the audience. So anytime during the program, if you're stimulated to ask a question, please enter it in chat. Otherwise, we ask you to stay muted through the program, and I will pose the chat questions to the panelists as well. At right about 5:30, we'll convene into breakout rooms, and these are going to be structured much like the table conversations that we've had in past in-person events. The only thing that's missing will be the white tablecloths and the wine and the beer and the nice cheese plates and desserts. But other than that, we hope to have some nice conversations in some small groups around potential research questions that are stimulated from the panelists' comments. I do want to make, after the breakout room conversations, which will go about 20-25 minutes, we'll do a brief wrap up and bring everybody back together and sort of look towards the future and what's ahead. I do want to mention that tonight's program will be recorded, and we'll post the recording on the website in a few weeks. So thank you very much for coming. And with that, I want to introduce our three panelists. First, Jeff Thomas, who's the CEO of Frontier Behavioral Health. Welcome, and thank you for participating, Jeff. Jeff has worked in the mental health field for the past 36 years. As licensed independent clinical social worker and licensed marriage and family therapist, Jeff has experience in both direct service and administration. He has worked as a CEO in a CEO capacity since 1997, and for the past 9 years as CEO of Frontier Behavioral Health, the largest provider of mental health services in the Inland Northwest, serving more than 20,000 individuals each year in 18 locations and 800 employees. Jeff also spent 13 years as adjunct faculty member in the Eastern Washington University School of Social Work. He's a board member and past president of the Washington Council for Behavioral Health. He's also serves on the Council for Behavioral Health and is on the boards for Better Health Together and the Empire Health Foundation. Welcome, Jeff. Next, I would like to introduce Melissa Hurt-Moran. She's now the Substance Abuse Disorder Clinical Manager at Camas Health. Melissa has a master's degree in clinical mental health counseling and has held licensure in Washington State since 2006. She currently holds national certification as a certified counselor and a certified addiction counselor. She is also licensed by Washington State for both substance use and mental health. She's worked in both inpatient and outpatient behavioral health settings as both a provider and an administrator. She previously worked with the criminal justice system as a regional director for 15 years and currently serves as clinical manager for the Kalispell Tribe of Indians SUD programs. Welcome, Melissa. And our third panelist is David Condon, who is Vice President, Sales and Marketing of Eastern Washington at Premera Blue Cross. In this role, he's Premera's leader in optimizing Premera's presence and success in Spokane and the Eastern Washington region. Prior to joining Premera, David served for 8 years as mayor of Spokane. And he reminded me today that he never made one enemy the whole 8 years he was in office. And before becoming mayor, David's professional career included serving in the U.S. Army, owning and operating several small businesses, and serving as senior staff in the U.S. House of Representatives. David holds Bachelor of Science degree in Finance and Military Science from the Carroll School of Management at Boston College. He's an Aspen Institute Rodell Fellow, a member of the Urbanova Board, GSI Board of Trustee member, Foley Institute Advisory Board, and the WSU Health Sciences Advisory Board. Welcome, David. The way we're going to proceed is I'm going to ask each panelist a question in turn. So in other words, I'll ask Jeff a question, and then Melissa, and then David, and then we'll cycle back through. And we may follow up if you have, I've asked the panelists to try to take maybe 2 or 3 minutes per question. And if we need to follow up further, we could possibly do that through the chat or if time allows through this process. So first of all, Jeff, what experience did Frontier have utilizing telehealth during COVID-19, and how do you incorporate telehealth in response to the pandemic?
Yes, and Paul, thank you for having me here. Prior to COVID-19, our experience with telehealth was extremely limited, to the point where it was just a single contract here or there for some telepsychiatry with rural providers. And some of that limited exposure had to do with regulatory limitations, but a lot of it had to do with just there was not really a driving necessity for that to occur. And then in late March of 2020, I remember distinctly having an emergency executive team meeting, sitting in the back seat of a car in Phoenix where I was attempting to vacation. And we made the decision to mobilize our staff and move nearly 500 out of our 700 employees off-site within less than 1 week's time. And several hundred of those being direct service providers. So we had to figure out how we were going to deliver care while doing that. And as we made that transition, began providing services using telehealth, using that term broadly, a combination of voice only via phone and voice with video using Zoom. Due to some significant limitations that I'll talk about a bit more on the part of our clients in terms of technology, a large proportion, about 80% of the services we provided over the 15 months subsequent to that time that were via telehealth were on phone only and not with Zoom, and which again, I can speak a bit later as to some of the challenges that presented. This past spring and summer, we transitioned almost all of our clinical staff, direct service staff, back on site, and we've continued to provide some services via telehealth, and we're still in the process of looking at what place that will have in our future, but it will definitely have a place, and be happy to elaborate on that a bit more in response to some of the other questions I anticipate you'll be asking.
Okay. Thank you, John. Huge impact, huge transition for you.
Yeah, it was.
Yeah. Well, we'll follow up with that in just a minute. So, Melissa, I want to ask you, in your role with the Kalispell tribe, what challenges have you faced regarding providing telehealth services, and how have you managed that?
So I think very similar to what Jeff was saying, we primarily serve Native American population and Native Americans living on or near reservations. And so internet services, reliable phone service are rare commodities for our population. And so that the transition to healthcare being remote in a system where the internet and the capabilities, the technology wasn't there, was a real area of shortfall for us. We also have a challenge in regards to privacy. Our populations tend to have more individuals within their home. So, families stay together, they live together. And so privacy was not necessarily an option. People did not have private space to be able to separate from family members. And so we definitely had to push the boundaries in regards to, how do we provide care? How do we meet the client needs? Resources, phones, not everyone, we take for granted cell phones today. But what we realized very, very quickly is that a huge portion of our population does not have cellular phones. And even, those that have phones through the state system, the limitations on the state service didn't allow for telehealth to be made quickly. There's other regulations in regards to, just being able to check, responses to medications and medication levels. There's so much that we can't do remotely. And so we had to, how do we do these services, ensuring that our clients are safe, but still give them the quality care that they desperately need.
Yeah. So some unique challenges in the rural communities and with the indigenous populations that you serve. Right. We'll follow up again with more on that as well. David, as a health plan, what has Premera learned with the use of technology in respect to behavioral health?
Well, I think just continuing this conversation that Jeff and Alyssa talked about, I guess we'd put it into three buckets. And iterative innovation is key. You try something out, it may or may not work, and Melissa talked about it. The second is, and I think Jeff hit it, which is integration with the traditional platform, the brick and mortar. A lot of people think, oh, it's a new vendor, it's all online. Well, actually, 95% of our claims were with brick and mortar, which really shows the resiliency of our traditional platforms to move into this new area. Jeff said it was in the back seat of a car. That literally, a lot of the management across some of our major networks, our partners, were in that same space. Maybe not the back seat, but definitely huddled around a table, trying to make things happen. The final is, and we knew this beforehand, but even greater, is increased access is a must. And this is it. I'll just touch, I think, on one area in the innovation space. We started a matchmaker process, which really is just an in-house service to remove the burdens of the behavioral health complex system. And just as an example, just to talk about one of the learnings from the innovation and the iterative nature of that, we have 253 members that so real small pilot program, but gives you an idea. 253 members were served. 19% actually requested virtual providers as their primary way of interacting with their provider. And then 58% were agnostic to it. They didn't care either way. They just wanted the access. So it gives you a little snapshot in some of those key early learnings that we're having from it, that there's an openness to this type of interaction with their provider, even as a primary, or otherwise we just want access, we don't care which way we get it, and that we saw 58% that way. So it kind of gives you a little picture of the learnings, and love to continue to talk about some of the other learnings we had across our 2.5 million members.
Okay, thank you, David. So again, having to pivot quickly and some major challenges in doing that, but also some unique opportunities emerging as well. Jeff, I'll ask you again. What has your organization learned from your use of telehealth over the past year and a half, and both in terms of the benefits and the limitations or the challenges of it?
Yeah, there's been a lot of learning because this is brand new for the most part. I do want to preface my remarks by saying I reached out to a couple of our valued rural partners for their perspectives, and there was a large overlap between the challenges that they experienced and we did, and the opportunities. And there are a few things that were more accentuated in their situation that I'll try and reflect in my comments, which I believe will resonate with Melissa, and things she'll be able to elaborate on more articulately because she lives in that world. But quickly, a couple of the benefits we saw, aside from the obvious one of being able to continue services in the midst of a pandemic, which was the driver, but we saw a significant decrease in our appointment no-show and cancellation rate. And in our world where we're dealing with, largely Medicaid population, many of whom are impoverished, have multiple challenges, in their lives, including homelessness or intermittent homelessness. Oftentimes we have no-show rates as high as 30% or higher, which is really a challenge to keep things efficient. We saw a decrease of by more than 10% in no-show rates and cancellations. To give you an indication for our organization, annually that translates into about 20,000 more kept appointments. That's a not small deal just unto itself. That decrease is directly attributable to the removal of barriers for individuals accessing services, transportation, travel. Even somebody who's not having to travel a long distance might have to, make several changes on bus routes, get childcare, take their youngsters out of school, maybe take time away from their job. So all those things became, less of a barrier as we began to provide services remotely. I think one of the things that was a byproduct that we didn't necessarily anticipate, but as individuals say would be out of the area on for one reason or another, medical appointments, maybe they were actually moving to another area. We could maintain continuity of services, whereas historically there'd be a disruption. We'd have to either take a break from services or transfer them to another provider. From a clinical standpoint, there's certainly a sector of the clients that we serve who have a fair amount of anxiety with coming into office settings, going into public, using public transportation. So for them, it was very beneficial and something they very much embraced, to be able to not have to contend with those challenges to get their clinical care. And something was brought up by both of our child psychiatrists, was they really felt like they got a lot more information being able to see the children that they work with in their home environment. A lot of information they could observe, because you can imagine it's cost prohibitive for us to have child psychiatrists going around doing home visits. So they were able to, through Zoom sessions, really be more informed and provide better care, they felt. Now, in terms of limitations or challenges, I'm going to sort of speed dig you through these because there's a whole lot of them, and none of them are preclusive of us wanting to continue in finding ways, but there are a fair amount. From a technology standpoint, three things I'll note. The first is just many of our clients lack the technology to be able to support the platforms for telehealth, for Zoom in particular. Thankfully, through Medicaid and Healthcare Authority, we're able to access smartphones on their behalf. Even those had their limitations, though. So a lot of our clients, as I alluded to earlier, just they were not technologically able to participate in full telehealth services as we would think about with the visual component. Some, and Melissa mentioned this, connectivity issues. Not a huge issue for us in Spokane County, although it was an issue to some extent in the rural areas. Absolutely, there's a real need for better connectivity in broadband and investments in that. Another, I think, piece related to technology is just comfort level of people using it. We may have been able to provide the technology, they may have had it, and that's just that's not something they were comfortable with, particularly some of our older clients. Our younger ones, they're like, sort of bring it on. That's the world they live in. From a clinical standpoint, I'll share a few things that stood out for us. For individuals with what we would refer to as mild to moderate symptomatology and acuity, telehealth tended to work better. For those with more severe psychiatric symptoms, very severely depressed, maybe experiencing psychosis, really difficult to provide the quality of care, the thoroughness of assessment that's necessary to respond to their needs when you're not getting the additional information that you can glean from being, sharing the same oxygen, so to speak, being in a space with somebody. For our clients being prescribed medications, which is a not small proportion, just things such as checking their vitals and their metabolic measures, rather important to medical care, hard to make that happen virtually. Right. Certain evidence-based practices aren't ones that can be provided unless done so face-to-face, so those had to be sidelined. Some of our psychological testing we do can be done remotely. Some of it cannot be done unless the psychologist is in the same room with the youngsters or the adults. So some of those had to be sidelined. And some clients just strongly prefer, I mentioned some clients with anxiety, it was helpful to them. Some strongly prefer to be seen face-to-face, and their level of engagement and development of the therapeutic relationship was really hindered by virtue of their only option being for the services to be via telehealth. A couple of other things I'll highlight that are just very pragmatic, but some of the necessary paperwork and signatures on consent forms and releases of information. How does that happen when, and there's certain regulatory requirements that were lifted temporarily, which was good, but those were hurdles that had to be cleared. Use of interpreter services became another challenge that was had to be transcended and sometimes was unable to be transcended adequately. Privacy, I think that was noted by Melissa, but depending on one's client's living situation, many of them have multiple individuals living in their home. So how do you ensure and do privacy, which is a very important thing in our field, of course. And then just, general distractions. I mean, from, kids in the background, dogs barking, repair people coming in. I mean, the things that we all experience, right, in these Zoom meetings, well, that's in clients' lives too.
Yeah.
And that could be pretty disruptive. And when we had the phone option, for folks who didn't have Zoom, boy, they might be, out shopping at Safeway and they're having a session. They might be, running errands, and it becomes difficult to really have the distraction-free environment that we would typically have in a clinic setting. I do want to touch a couple of pieces having to do with staff standpoint. As we made that transition, although telehealth doesn't have to be staff working from their homes, right? Telehealth can be clients in their homes and the provider in an office setting. But as I alluded to, our staff were all at home for a period of time, for the most part. Some had an option to come in, and gradually some did. But that is some form of challenges, even though our staff appreciated that and liked it. But one of the challenges is that there's just a much greater degree of inconsistency and variance in the professional environment that you might have. So when you have 250 to 300 people providing care from their living room, or from maybe not their living room, maybe their kitchen or their dining room or their bedroom, depending on their situation, and depending on what sort of their situation and how many pets they have and how many kids and what else is going on, that it's just difficult to have the same consistency of professional environment. I think also the confidentiality and the ability to maintain that's such a hallmark of what we do in our work in behavioral health, and ensuring that when somebody's working from home, whether it's paperwork being left out, somebody else seeing a face on a monitor of a client, somebody overhearing something that's being said. I mean, all of those things become much more possible, of course, if the clinician, the provider is working from home than if they're in the office setting. I think also providing adequate supervision was a real challenge for us. In our organization, we tend to have a lot of clinicians who are newer to the field. At any given time, we have a few dozen interns, and supervision is just a real critical part of the support that we provide for them. And while we're still able to provide, scheduled weekly supervisions that would occur on site, so much of the supervision that clinicians really require and benefit from are the contacts that happen outside of that scheduled hour. It's the going down and catching your supervisor in between sessions, the 2-minute conversations, to try to pick their brain on something. Well, that became much more difficult, and our clinicians really missed that, and the supervisors missed that contact. Final piece I'll touch on, which still has to do with staff, is just we heard from our staff, although they enjoyed working from home, they really missed the level of support they received from their peers. The collegiality, the contact that they would have, the ability to, maybe it wasn't something they wanted to bring to their supervisor, but they had a really tough session, maybe a highly suicidal client, and just to be able to go down the hall and talk to one of their teammates, fellow clinicians, and get some support from them. Or maybe somebody observing a colleague having a tough time and checking in with them. Those were much more difficult to have happen when you're all sitting in your own domiciles providing services via telehealth. Yeah. So it's just a quick highlight reel and some of the benefits, some of the challenges that we experienced through this process.
There's a lot there. Certainly benefits and positives, but there's many challenges that have to be managed carefully and thoughtfully. Thank you, Jeff. Let's get back to Melissa now. Melissa, you talked a little bit about the challenges in a rural environment, and particularly with the indigenous communities that you serve. Can you say a little bit more about some of the specific challenges that your clients, maybe even those who are in need and not clients, but trying to reach out and help people who are in need? Maybe they don't even know they're in need, but how do you manage that in the rural communities and the indigenous population that you serve?
Jeff did an amazing job of really capturing, I think, a lot of the clinician concerns, but that's a real struggle for us, especially serving the population that we choose to. Native Americans have not been treated the best throughout history, and they have a lot of historical trauma. And so attempting to get them to trust us as providers is a barrier. We have to build those relationships, and we have to continue to prove who we are, and that we're here, and that we're going to continue to be here every single day. But with the pandemic, what they faced is that we weren't there. They couldn't just stop in our office. There wasn't somebody on the other end of the phone. Our phone wasn't being answered. And so we had to get creative in regards to how do we get this message out, and how do we reach our population and be safe? How do we communicate, the safety and address concerns about the pandemic? Because that's a reality, how much of this pandemic is real, how much of it is made up. And so those are things that we had to prepare ourselves for as well. So, we had to get education by medical doctors, and we had to research the CDC every day as it was changing. And we still had to put ourselves out there in the community. We had to be willing to go to gatherings, and we had to be willing to be at funeral services, because if we weren't at funeral services were not an option to not have. This is culture. This is how you say goodbye. This is the only right way. And so we had to be there. We had to be part of the community, and we had to communicate that in a way that was respectful to our tribal members, respectful to our clients, and try to continue to give them whatever resources that we had. We had to also confront the state. We had to confront the federal government and say, what are we doing to ensure that these services are available to the tribes? What are you guys doing to support, getting internet services? How, these phones that you guys are offering are great, but they don't work in the climate that we're serving. So what can you give us that meets the needs of the tribal population? And we just had to consistently be at the table and serve ourselves more of an advocacy role than what we would typically do. A lot of times in counseling, we work to support our clients in empowering themselves and being a voice and speaking for themselves. And we had to push ourselves to be a stronger voice and to go out there and say these things so that, this population was being looked at. Many tribes got, some negative spotlight as they tried to protect their reservations, as they closed reservations, and people were not always happy with those choices that the tribes made. And that created a barrier. So then we had to go back out and say, no, we support you. We understand why you're making that decision. This isn't, this is one person's opinion. These guys aren't speaking for everybody. Because all those things created barriers as we're trying to serve an underserved population. And so our providers really kind of had to be really a voice. They had to advocate while still, providing the counseling services that were desperately needed.
So there's a lot of work in outreach and building trust and advocacy, and even trying to get resources that would be helpful to you, which may be available to many communities, but not so much in your community. Thank you. David, I wanted to ask you, from your perspective, you've been across the state and in Alaska, what disparities have you seen in the availability of and use of technology such as telehealth?
Well, as a health plan that is only here in Washington State, and you mentioned in Alaska, there are very similarities, especially in eastern Washington and parts of Alaska, and maybe exacerbated in Alaska because such the remote and the native populations, indigenous populations there, with many of the pieces that Melissa talked about in concept, meaning that they have their own challenges within those populations. But it was from the top, the number one issue is technology and technology, not only access, but as part of their culture and their familiarity with that level, I think is a key piece. One of our clinical directors said it right off the top, is that isolation in those communities was only exacerbated by not having the technological connectivity. But there's also a second thing, and that is, especially with behavioral health, but really throughout health in a broader sense, is really those social determinants of health were only exacerbated in these rural populations. And so whether we're looking at housing, or we're looking at access to food, or we're looking at, yes, access to healthcare and behavioral health. And so we really saw and do see a dramatic need in that primary care, collaborative care model, that really behavioral health needs to be integrated in that. And it touched, in a big way on, and I think we are later in our conversation going to talk about the workforce needs and the professional needs, and really the throughput. And yes, this existed prior to the pandemic, and only has been exacerbated. And one of the key areas, I think, and especially with so many higher education leaders on this call, really a critical need that we're going to see going forward, and that is, how do we reimagine and really say and look at our educational and our professional expertise throughout the state and in Alaska. But it is that need for those social determinants of health, that integrated model, that collaborative care model. And another thing, and again, and it's not just for our members. Obviously, we are a health plan, but we took a real critical role and look at the wellness and health of the communities that we're in, whether people are our members or not, and made a major contribution of really looking at those critical critical crisis clinic beds, and having those, especially, and we partnered with the Department of Commerce to administer these, and we also partner with the Empire Foundation to look at those critical needs, and especially in behavioral health and those beds throughout our system. And there's regulatory issues, there's all sorts of things, but also capital and operating, but really saw that as a way that not only can serve our members, but more broadly and more appropriately serve all of our rural areas, whether it be in the state of Washington or in Alaska, which really affects so many. So really, it's kind of those three things: the access to the resources for really looking at those social determinants of health, which exacerbate behavioral health and people's well-being, really focusing on collaborative care models, and maybe providing technology in that space, and bringing it into those primary care offices with the professionals like that are on the panel with me today, and their staffs. But how do we integrate that? And then finally, I mean, there's a need for definitely infrastructure of actually, clinical, and especially in the crisis space.
Thank you, David. We have some other questions, but I want to focus before we turn to the chat. And again, I want to remind the audience, if you have a question that you want to pose to the panel in particular, or to a person in particular, or the panel in general, feel free to do that in the chat. I want to ask, if you would, from your perspective again, what kind of research questions do you think do you have, and maybe that some of the academics in the audience might be interested in helping you address? Just think about research questions that might lend themselves to academic help, as well as maybe student project help, those kinds of things. I'll start with Jeff. But why don't we just open up to the panel? But Jeff, you want to start, and anyone can jump in.
Yeah, sure. I've just got a few thoughts of possibilities. I think this is, it's not brand new in terms of behavioral health being provided via telehealth, but for to be something that's being provided so broadly to such a diverse array of populations, then I think there's all kinds of things that aren't yet known. I mean, some of it just has to do is, what differences, if any, exist with regard to the effectiveness of treatment when it's provided via telehealth versus in person. And then I think there's subsets to that, which is, what are the differences that make a difference? So is it different for certain age groups in terms of the efficacy, the engagement of clients? Are there differences in terms of individuals based on diagnosis or acuity? Are there differences in effectiveness, based on, well, how does telehealth impact client satisfaction? We know satisfaction with a healthcare provider can have a lot to do with how much somebody benefits from it. Certainly that's the case in behavioral health. So are there, what are the differences there? What are the differences also with provider satisfaction and the different tentacles for that? I talked a bit about, how there's some advantages, but some disadvantages, some challenges. I think, those are some, and I think there's much more, but present some opportunities for research to be assisting in some of the learning.
Just to follow on from that, many of the same things, in our team, we have an internal team that's cross-functional because it's not just behavioral health, like Jeff said, and how do you integrate? But one of the key ones, especially that we're looking at, is the clinical outcomes, and from that, then what is the experience of our members, and what's the experience that they have, and this ultimately is going to lead into the regulatory, and my background in regulatory and government, whether it be at the federal or local level. But what are those quality measures that we're going to use, and what are the regulatory parameters around that? There was a lot of innovation, a lot of bootstrapping that worked, or we think it did, but typically as we build out the regulations and the quality measures, especially as we look at reimbursement models that in part look at quality and outcome measures, and what are those? And so I think there really is an intense need to look at, yes, the research, but then how does the applied side of that on policy and regulatory, especially in the area of reimbursement, and ultimately, obviously, the outcome of and the outcomes of the clinical experience.
Mm-hmm.
Okay, thank you, David. Melissa?
Well, I'm looking at it from a provider's standpoint, what does work remotely? I mean, most traditional models have been studied in utilizing the traditional care model of, one provider, one client. Is groups as effective in through the Zoom application, or should we move Zoom, or when a person can only do remotely, should we be seeing them only in individual sessions? We recognize that groups have such a therapeutic outcome for clients, but do they get that same therapeutic outcome, or how do we do services differently so that they get that same benefit? Just the application of the theories and the tools and the techniques that we practice, nothing has really been researched to say this is the best way to facilitate, CBT through, telehealth. And we don't have those tools available to us. Most providers have never provided remote care until the pandemic occurred. And then we all pretty much had a Jeff Thomas moment. I personally was in the Houston airport, but same concept. And we figured it out. I think my team and we transitioned in 17 hours, and we didn't know what we were doing. We just kind of stumbled through. We learned many lessons along the way, like David was saying, but we want to know, how do we actually practice? How do we actually do these assessments in a remote setting? Because most assessments, even you're looking for their body language, you're looking for how they respond, and we don't get to see those remotely. Zoom freezes, we cut off patients in remote areas. Zoom is not as effective, or telehealth services with video are not as effective in areas with bad internet connection. Even Teeny has terrible internet. So we often have clients without any kind of video. So we literally see no facial responses. And like, if you're watching for a trauma response, you're looking for how their face responds. And so how do we see those things in this model? I think, just going into the practice model, I think is where, providers are hoping, colleges take it, is how do I provide the best quality treatment, in an evidence-based manner in this environment?
It's helpful. Good questions. I'm going to turn now to some of the questions in the chat. Someone asked, this is for the panel, and anyone could respond. Has integration of behavioral health and primary care impacted telehealth delivered services during the pandemic? integration of behavioral health and primary care impacted telehealth delivered services during the pandemic?
From our perspective, both we run and really at the pilot stage, just 4 clinics here in Spokane, and looking and have them now in Eastern Washington, Wenatchee, and Yakima next month. But we've integrated behavioral health into those, and not only that, because we're at the front end of it, also have integrated just physically the patient care rooms to be fully integrated with telemedicine. So if you go into the office and are in a exam room, they're much more comfortable, and they don't look as examish as they used to. And not only that, but it'll be the same room you see if you have telemedicine or a remote or virtual care appointment also, so that there's just familiarity. I think in the long term, telehealth is here to stay, but I think it's an integrated model. And I'll just say the resiliency of, the stories that we just had today from my 2 panel colleagues, that happened over and over again. The primary care, the providers, the frontline staff were able to make it work. Now, make it work. I'm very interested in on the provider research and what's the impact. I think that's real. When you have an encounter that doesn't go well, you're around your colleagues versus sitting, isolated in your own home or wherever you're providing that service. But we definitely have integrated it, and I think it's here to stay. But it's an integrated model. It's not a either or. It's an and. But I think that we're going to have to continue to do research on the model. But we've definitely even taken it into our new clinics as we build them out.
One way I think about this is, we are, as a behavioral health provider, we are not endeavoring to also become primary care providers, but we work very, very closely with primary care providers. And one of the things that has been a challenge, for many years, we've been trying to figure out how to contend with is how to statistically the percentage of individuals referred from primary care to a behavioral health provider who actually show up and get engaged in services is very low. And actually, I say statistically loosely because nobody knew. The primary care providers say, hey, go see Frontier, here's a card, here's a number. And the next time they show up for a physical or an appointment at the primary care, say, hey, do you ever go get care? That's how loose it was. Mm-hmm. So we were in process pre-COVID, PC, of trying to develop more seamless pathways. And in one way in which we were advantaged by telehealth was we were actually, previous to this, we were looking at putting intake clinicians at a couple of different CHAZ clinics, which would be great, right? But you do have, it can be a little cost prohibitive, somebody sitting there waiting for when a referral will come. Well, by virtue of us being able to do our intake assessments virtually, boy, that seamless handoff became pretty easy. It's like they're with the provider, and within moments, it's like they're talking to one of our customer service folks, and a few moments, then they're still sitting at the CHAZ clinic. They're getting their intake assessment with our clinical staff. Doesn't get a whole lot more seamless than that as far as removing a whole lot of different barriers. So that's just one example of how even across organizations, telehealth, I think, really assisted in integration efforts.
Good. Thank you, Jeff.
I think it also allowed, like, the exception that we got for signed ROIs. Like, I could get a verbal consent for a release of information, and that allowed for me to communicate seamlessly with that primary care provider that was the referral source, or that I need to talk to you about medications or medical issues that were going on. And confidentiality is wonderful and it needs to be protected, but being able to get it through that verbal source was not only convenient for the client, but it allowed for me to be able to flow very quickly into that coordination with that primary care provider. And so that was definitely a benefit throughout the pandemic.
Mm-hmm.
Good. We have some other questions in the chat. Some of them are very long questions. This one, though, there are a couple that have to do with credentialing or maybe re-credentialing. This one says, one of the big issues we are facing with the next generation is credentialing challenges. Need to re-credential students for everything, including telehealth. Wazoo and UW are each spending $500,000 per year just credentialing medical students over and over again for venues they rotate through their clinical placements. Any hope for a statewide agreement that would include telehealth? That's more of a, sounds like more of a policy challenge.
Well, I absolutely cannot answer that question. So I'll preface with that, but I'll share that, it's the state had to invent some things at the outset. And so it's okay, well, we're going to require, in order for somebody to, be using a Zoom license and provide services that are provided in the behavioral health world and to the public, health sector, you had to, essentially receive a certain modicum of training, and it wasn't huge. Is pretty small amount of training and sort of sign in a test. Now it was nowhere near a certificate program. I think it was what, Melissa, maybe a couple hour thing that people participated in these webinars, but it was at least something to sort of acquaint people with the basic do's and don'ts and some of the parameters of telehealth. So and that was sort of, it became their credential, quote unquote, as far as their ability to be, providing services via telehealth. I've not heard discussions, and maybe David or Melissa, you guys have, as far as something that's bigger and broader that would be a necessary credentialing process that people would have to go through to be providing telehealth or telebehavioral health in the future.
I think that I interpreted that as credentialing with insurance companies. That's how I interpreted it. So when we work with, we have to get re-credentialed with insurance companies. So like if you switch sites, you may have been credentialed with Primera before, but you have to get re-credentialed with Primera at your new location. And so it is a timely process as new providers move. There's always, and it does. I think most places have to specialty staff that just do credentialing applications because they are a tough one. We do all enjoy signing that repeatedly, but they do take some time. That's how I interpreted the question. I'm not sure.
Well, if that's the lens, it was like, I'd say our credentialing process was a headache and is a headache, but it's no more of a headache necessarily through telehealth, just still a headache.
And this is where I think the critical examination of outcomes, the critical examination of the impact of telehealth, to and to be frank with you, is to look at the regulatory requirements in the insurance space that causes us to do these sorts of things. But of course, the regulators are going to want to see those studies that either verify that it's necessary or that it's not necessary. So that's where a lot of the clinical research is definitely necessary, but what is the impact then on policy and regulatory requirements, and what was the genesis of those regulatory requirements, and are they needed today? Frankly, you saw it on CMS rulings at the federal level, you see it at the state level, and if we got a window into the world where that it could look different and it's much more mobile, and that's just not the way the system was originally designed. It was a fixed facility system, and now we see the integration, and it was overnight. I mean, Jeff talked about it, Melissa talked about it. We saw it on the payer side of just a dramatic increase in the use of telehealth, and literally it changes regulation, it changes physical structure, it changes the way we educate, and that's why a lot of these things will need to be researched so that we can make smart policy for the long term, not just in response to the pandemic, although hopefully we've learned quite a bit out of it.
Thank you for that. We have time for one more round of question before we move to the breakout rooms, and we hope everyone will stay with those. We'll have groups of 6 people that you can really dig down into some of these ideas and topics in more depth. Here's one that maybe points us to the future. What will behavioral health delivery look like as the pandemic winds down? Sort of more of a future focus.
Well, first of all, I admire somebody's optimism that there's going to be winding down of the pandemic. So yay for that. Yeah, we're all ready for it, right? Right. I mean, I can take a stab and I can share what our organization is doing. I can't say what it's going to look like broadly, although I do know I've talked to enough colleagues that I think many are thinking as we are, which is it's going to be a combination. We're going to have some sort of a hybrid model. There's no going back, nor do we want to. We've learned some things as far as some of the benefits that I've mentioned and others have mentioned. But I certainly don't see us doing only telehealth for the reasons I described from some of the challenges. But here's some of our initial thinking, and literally we're having these conversations as we speak in meetings yesterday and today and tomorrow. I mean, literally yesterday, today, tomorrow, we're that much in the middle of it. But for instance, we're most likely going to require the video component for many of our treatment modalities, just because the phone only isn't sufficient. And some will have to be face-to-face. We're also going to be requiring initial assessments, the face-to-face, and it's only after a treatment relationship is established with one of our providers that telehealth would be an option. And at that point, it'd be if the client desires it. And even with that, there'd be caveats and clinical parameters as far as severity of client illness or their acuity as to whether it be appropriate or not. And we also feel like for some of our clinicians to be able to work from their home settings part of the time could help with recruitment and retention with the really serious workforce challenges that are out there. So there's a lot more kind of meat to put on the bones, but we really feel like kind of those are some of the elements that are informing our thinking, that there definitely will be a role, and a not small one, for telehealth and behavioral health.
Thanks, Jeff. David?
I think the only piece I would add is the integration. By no means is primary care taking over behavioral health, but I could see a day, especially in our clinical setting, to facilitate that handoff to the specialist, that maybe that interaction with the specialist is in your primary care's office, so that actually happens. And so I could see a primary care doctor say, well, we're going to refer you to Spokane Behavioral Health, and you can sit right here in this exam room, and we'll bring on a clinician and see those type of contracts happening, to where then Jeff or Melissa, could have somebody right there and maybe be even appropriate, maybe more appropriate culturally, may appropriate with specialty, versus just trying to figure out, because of the shortage in the workforce side, just going to whoever's available. Because unfortunately, oftentimes, especially in my time in the public sector, behavioral health has not been a mainstreamed healthcare area, meaning that people still see it as separate. And to me, it's fully integrated. Your physical health, your behavioral health, your mental health, everything is integrated. And so I see a real opportunity of really leveraging those partnerships with our specialty, providers, but maybe in the setting, and you're able to do that because you could better utilize the specialist, the behavioral health specialist, in multiple locations, rather than trying to put them in one spot, especially when you look at in the rural areas, so many of the other things is causing the care not to happen. What we want is an experience for any of our members and members of the community, and you want them to see that care. And in many cases, and I think, one of the key areas is, are we seeing better clinical outcomes from this interaction? Someone goes to their normal doctor's office, they get the privacy and all that, but they don't have to go across town or even from Colville into Spokane, but they can really see somebody that's clinically appropriate, culturally appropriate, and yeah, maybe that is over a telehealth connection.
We are a fully integrated care system, and I think for us, it's definitely here to stay for us. It's easier for a lot of our clients, but there are shortfalls. We can't pretend that there isn't. And so how we're meeting and planning every single day, we do see the benefits of having clinicians work from home and helping them, support them in that work-life balance. And that's important because behavioral health providers, the pandemic did not help the shortage of behavioral health providers at all. We're seeing less and less staff available. And so recognizing that there is going to be a component, it's going to increase our staffing needs. Like, we're going to have to talk about these clients more often and figure out, where is the best care of need. And the clients are going to have to be interactive in that process, is kind of how we're seeing it. Is we're going to have to take it one day at a time, one client at a time, one symptomology at a time, and saying, what is the best model of care for this client today? and being flexible to change it tomorrow based upon what the client's need is.
Thank you to our panelists. There are other questions in the chat, very good questions. And we're running into a time crunch now, and I'd like to move into the breakout rooms. What I'd like to do is publish these chat questions to the panelists, and perhaps they would take some time following tonight to make responses to those questions so that we can communicate those back to the participants. So we have a lot of questions, not enough time to address them in any depth. I'm hoping that in the breakout rooms, groups can sort of decide what kind of research question they want to pursue. And so there's a little flexibility to maybe dig down to some of these questions that were unanswered during this particular part of the program. I'm going to turn the time briefly to Amy. She's going to talk a little bit how the breakout rooms will be structured.
Yeah, so I posted in the chat a link. If everyone just want to go ahead and click on the link, it's going to open up a form that we're hoping that you can answer some of those questions in the breakout rooms, and then hit submit. That way you don't have to do any kind of note taking or emailing it afterwards. It's really simple, just to fill out the 3 questions that's on that link. It'd be best if you click on the link now. That way, when I move you to the breakout room, you all have the link available in the background. That way, because once you're in the breakout room, you won't be able to see that link here in the chat. So I'll give you a few seconds to do that. And then we're going to go ahead and move you into the breakout room. All right, I'm gonna go ahead and open up the breakout. Everybody got the link? I'm gonna open up all the breakout room here, and then I'll send a notice just about maybe 5 minutes prior to 6 and bring everybody back here for the wrap up.